Now we're going to discuss the behavioral psychologic disorders, the common ones that will appear on the exam. We'll start off with some of the vegetative disorders. Pica. It's going to be repeated or chronic ingestion of non-nutritive substances. So these are the babies or the children that will eat dirt or just chew on ice cubes or whatever. Predisposing factors include mental retardation, also a lack of parental nurturing, and a family disorganization. Sometimes you'll see this where, for example, in patients with lead poisoning and similar things like that. Also poor supervision. Associations include autism, also brain disorders and low socioeconomic status, particularly because of lack of nurturing, disorganization, and supervision. Risks, like I mentioned, are lead poisoning. Also iron, it's hard sometimes to say, is the lead poisoning because of the pica or is it progressive pica because of the lead poisoning? So you will see an association of lead poisoning and pica when you read the test questions. Also iron deficiency, a risk for that, and parasitic infections because they're putting all kinds of things into their mouths and so they can infect themselves with a parasite. We're going to discuss enuresis now. Very common one to get asked on the exam is enuresis because it makes you think of certain things while you're reading the test question. Again, some of this is developmental. They might give you the age of a patient and you have to know, is this patient old enough or not to have voluntary control of bladder or of bladder function. So if they tell you that the baby is 3 years old and is having accidents, don't worry about it. If they're telling you the child is 6, 7 years old, absolutely you need to worry about it. So the age is very important when you read the test question, and that's another way of asking a developmental question. Enuresis is going to be the voluntary or involuntary repeated discharge of urine, and use 5 years of age as your cutoff. Okay? If the baby is less than 5, let it go. If the baby is older than 5, let it go. Unless, of course, the baby's had been quote-unquote toilet trained for quite some time already, even though it might have been at an earlier age. We talk about primary versus secondary. Primary enuresis is that baby that has never been significantly dry for any period of time. Secondary enuresis is the child that has been dry and now is starting to have accidents. Right? So you need to look for that and make that distinction when you're reading the test question. If they tell you that the baby's never been dry, you think, oh, this is primary enuresis. It could be an anatomic problem or it could be nocturnal enuresis. We'll discuss these in a minute. Secondary enuresis, think of psychological problems. Doesn't take a whole lot of lab tests to make the diagnosis. Usually the basic test you need to get is a urinalysis, and then depending on that you go along other ways. Primary enuresis is the patient has not been significantly dry for any period of time. And secondary enuresis is a patient that has been toilet trained and has had success and now starts having quote-unquote accidents. When you think of primary enuresis, the main one for the exam is primary nocturnal enuresis. When you're reading the test question, look at the age of the patient because you need to know if it's less than 5 or greater than 5. Look at the sex of the patient. Primary nocturnal enuresis is almost always seen in boys. That's an important clue. The other thing to remember for primary nocturnal enuresis is the child is dry during the day. It's only at night. So you will get a history of a child that keeps wetting the bed at night, and during the day it's not a problem at school. He can go to the bathroom whenever he wants. This is usually a disorder of the child not waking up in the middle of the night, or sleeping through the urge to get up in the middle of the night and go and void. So they just have enuresis. And so it's a classic example. If you have to be pushed to do any tests, do a urinalysis. Other causes of enuresis we'll discuss in a minute. But with primary nocturnal, it'll be normal. It'll be a normal urinalysis. And the treatment here is going to be basically time. You can try bedtime alarms. A lot of times they don't wake up the child because they sleep through that alarm. However, sometimes using, for example, DDAVP or imipramine will help with the child not voiding through the night. This is useful for if the child has to go to an overnight sleepover or away to camp or things like that. But once you go off the medicine, it comes back. It doesn't cure it. Usually as they get older, they get over it. Another cause of primary enuresis, but not primary nocturnal enuresis, is some kind of anatomical malformation. So they could have posterior urethral valves and it dribbles out. They could have some kind of fistula, and so urine kind of dribbles out all the time. So you do have to worry about anatomic malformations. But typically for the primary, look for it dry during the day, wet at night. That's going to be nocturnal. Secondary enuresis means that there's something else going on. And the most common cause of secondary enuresis, this is the child that has already been dry and now is starting to have accidents. The most common cause of secondary enuresis is going to be psychosocial. So look for recent loss. Somebody in the family died. Look for a bully. Look for something, divorce in the family, some kind of psychosocial stressor which is now causing the child to do this. A new baby in the house, and now the older child starts to have accidents, and that way it kind of gets attention. Other causes of secondary enuresis, not as common, for example, could be a urinary tract infection. In that case, the child would probably complain of dysuria, and you can see increased frequency. Also remember diabetes. Babies or children with diabetes many times will present with polyuria, polydipsia, polyphagia. So the polyuria, they may be having accidents because they can't get to the bathroom in time. So those are other lesser causes, less common causes of secondary enuresis. Encopresis is the passage of feces into inappropriate places after the age of 4. And again, a very common cause of encopresis is going to be psychological. So for example, toilet phobias, aggressive toilet training, aggressive treatment of diarrhea or diarrhea in itself. Patients that have painful defecation for whatever reason, be it constipation or diarrhea, will then try to hold it in, and then these children do not respond to the normal stretch response and can have encopresis. It is also associated with global developmental delays, so it can occur in association with that, or it can occur in an otherwise normal child. And it's very important that you do a rectal exam on these patients, and you will palpate hard stool, because part of your differential diagnosis is going to be Hirschsprung's. Sometimes Hirschsprung's can present outside of infancy. And in the case of encopresis from constipation or all these other factors, you will be able to palpate stool in the rectum. The treatment usually involves, if they're really constipated, cleaning the baby out, the child out, and then sending them on a regimen, nutritional, and certain times that they need to go to the bathroom. And if they have any psychosocial issues, they should also be addressed. The parasomnias, these are the sleep problems. These are going to be nocturnal behaviors. They're episodic, and they can be disoriented. They can also have some skeletal muscle disturbances. And it is associated usually with CNS, central nervous system immaturity, and so with time these babies tend to outgrow them. They include sleepwalking, so they'll get up and walk around, which can be dangerous because they can go outside if you're not careful. They can have sleep terrors and nightmares. Okay, so sleepwalking and sleep terrors usually occur during the first third of the night when they're in a different phase of sleep. These patients do not have any daytime sleepiness. These patients typically do not have recall of the event, and it's a very common finding in the family. So you'll have a family history of patients that also have sleepwalking or sleep terror. The parents or other siblings may have that problem. And it is more common in younger children. The treatment is basically reassuring the parents. For sleepwalking, you definitely have to make sure that the doors are locked so they don't head outside or get into dangerous places. And you try to avoid any factors that can make things worse, such as sleep deprivation, and of course the safety precautions. The other parasomnia is the nightmare. This occurs in the later part of the night, in the later part of sleeping. These babies may come out of bed, but there's little motor activity associated with these. These babies are very easily aroused and awakened while they're having their nightmare. They will, however, have daytime sleepiness as opposed to the sleep terrors, where they just kind of basically basically sleep through it and just wake up and cry, and then they go back to sleep. These babies will have sleepiness during the day, and they'll have a very vivid recall of what happened. It is an actual dream. It's a bad dream, as opposed to the sleep terrors, which is just a completely different, and they just sleep right through it and have no recall of what happened. Usually there's not a family history of nightmares.